Long before the days of routine brushing of teeth, dental hygiene was not lost on ancient humans. Evidence has been found that even up to 14,000 years ago, oral procedures were being performed using simple stone tools to chip away portions of bad teeth. With the advent of anesthesia a few millennia away, one could only imagine that these procedures were not pleasant to the patient, but must have been less painful than a chronic broken tooth. Record-keeping for dental pathologies can be traced back to around 4000 BC, where ancient Sumerians documented causes of tooth decay. However, at the time, the causative agent was attributed to toothworms. What's even more interesting is that this belief was held up to the 18th century, with toothworms being attributed to dental disease in the ancient texts of China, the Roman Empire, and the Middle Ages. In 2009, researchers at the University of Maryland uncovered previously unknown microscopic supporting structures within a dissected molar. While the exact purpose of these structures is still unknown, the researchers describe them as having a worm-like appearance. It would seem the ancient views on cavities may have some grounding in reality after all.
Welcome to the Head and Neck Lecture for Clinical Correlations. I'm Matt Guerin, and we have a lot of topics to cover for this lecture, so buckle up and let's get started. So for this lecture, we have 11 objectives to go over, so make sure you're looking over those, and if you have any questions, feel free to reach out. So as you can see, we do have a lot of topics to cover for this particular lecture, pretty much anything associated with the oral and nasal cavities. So we're going to be looking at tongue, mandibles, maxillas, nasal cavity specimens, salivary glands, and even radical neck dissections, which you would have learned about in larynx as well. So let's go ahead and get started with the embryology component. So development of the head and neck region is pretty straightforward. Starting in the early 4th week, we get the beginning of the pharyngeal arches from mesenchymal tissue. And by the end of the 4th week, we have 4 pairs of these arches. Now another word for these arches is branchial arches that you might hear, and branchial is another word for gill. So it can kind of give you an idea of where these arches come from, evolutionary speaking. So aquatic animals would have these to go on and make gill supporting structures. But unfortunately, as humans don't have gills, so we have to sit there and breathe boring air, which means these are going to go on and produce our head and neck supporting structures. So externally, each of these arches is going to be separated by a pharyngeal groove. And so you'll see those on the lateral aspect here. In grooves 2, 3, and 4, will actually merge to create a super groove, also known as a cervical sinus, which should obliterate during development. And we'll see that congenital anomalies can exist when this cervical sinus does not obliterate. Get things like a cervical cyst or a branchial vestige. And keep in mind that pharyngeal and branchial in this context can be used interchangeably. So when we talk about pharyngeal grooves, you can also say branchial grooves. Now, going on the inside, lining the inner lining of our embryo, we have pharyngeal pouches. So these are going to be separating the pharyngeal arches on the inside and help form the pyramidal structures of our pharynx. So mix up the grooves in the pouches. Grooves are on the outside, pouches are on the inside here. So each of these pharyngeal arches is going to go on and create some important structures in our head and neck region. So the most important one we'll talk about for this lecture is the first pharyngeal arch, which is going to create your maxillary and mandibular prominence. And these will go on to basically be primordials of the maxilla and mandibular components in the adult. So you can see here in the purple is our maxillary prominence, kind of creating that upper lip region, and then the blue is our mandibular prominence, creating that lower lip region. Our second pharyngeal arch just goes on and creates the hyoid bone, so that little supporting structure at the bottom of our jaw, kind of right above the larynx there. And then during the 5th week, our 3rd and 4th arch are going to actually merge and create a lot of our supporting cartilages in the larynx. So a couple of congenital anomalies that I already mentioned that if our cervical sinus does not obliterate, we might see are the cervical cyst or branchial cyst and a branchial vestige or cervical vestige. Again, using those terms interchangeably, anything associated with our gillish regions here in our neck. So the first is the cervical cyst, and this is going to be a remnant of that cervical sinus, and it's just going to fill up with fluid, as you might expect a cyst to do so. Now what you'll see is it's going to be located along the inferior aspect of our mandible, just anterior to our sternocleidomastoids. So you'll see them kind of right up in this local area. Now the vestiges are going to be bony fragments that are actually going to be on the lower end of our neck and the inferior portion of our sternocleidomastoid, just anterior to that. So cervical cysts should be up a little more superior. Cervical vestiges should be inferior. So none of these are inherently life-threatening, and someone could theoretically live with these if they wish not to get them treated. But they are worth noting, and usually surgical excision is going to be pretty curative in all these instances, so you might see these specimens come down to the lab. So as our prominences come together, particularly our maxillary prominence, we'll start to see the formation of our palate. So palaenogenesis occurs starting in the 6th week, and it's going to last for about 6 weeks all the way until the 12th week for this to occur. And what we're going to see is sort of the merging of these little nasal components you can see in the embryo here. These medial nasal prominences are going to start to merge, and you'll have a primary palatogenesis, which is going to be a premaxillary region. So anything kind of just before the bone there is going to form in that primary palate. And then you have your secondary palate, which is going to be everything from posterior to that, so your hard and soft palate, again, coming together to merge. So what we can see with palatogenesis is a failure of fusion from either the primary or the secondary palate can give us either a cleft lip or a cleft palate or a combination of both. And it really is just going to vary depending on how the presentation is and what particular components fail to fuse. So some of the things that you would look for is it going to be an anterior cleft or posterior cleft or both? So the anterior cleft is going to be the lip, where you pretty much get the lack of fusion of your primary palate, and the posterior is going to be the lack of fusion of your secondary palate. Additionally, you want to look at, is it going to be a complete or incomplete? So most of these are going to be a complete lack of fusion, which sounds kind of counterintuitive. But if it's complete, it's going to involve pretty much the lip and the maxilla. And then the other thing is it's going to be unilateral or bilateral. Is it kind of along the midline? Do you see double clefts due to a lack of fusion, or is it just a singular cleft on one side or the other? So things to note. You won't really see these as a surgical specimen, but there's something that you would document if you were doing a pediatric autopsy, let's say. So with embryology out of the way, we can take a look at the anatomy and histology of the various components of the oral cavity. So some of the stuff we're going to look at for this particular component are teeth and tongue, mandible and maxilla, a little bit of the pharynx, as well as some of the salivary glands. So grossly, a couple structures to be noting of is obviously we have the lips on the anterior surface, and those are going to kind of convert into our mucosa. Each of our lips should be attached by a frenulum, which is kind of a nice little name for a connective portion from one part of tissue to another. Opening it, you should be able to identify the tongue, hopefully, and then going back to that, kind of the start of our pharynx is going to be the glossopalatal arch, where it's going to converge to our uvula, and just behind that is going to be the pharyngeal-palatine arch, right before we get into the oral pharynx region. Those are the key structures to really worry about. There's really not a whole lot going on of note in the tongue and in the oral cavity region. Just being able to open it and look at it. Histologically, so you're going to have to be able to differentiate between the keratinized and non-keratinized stratified epithelium. And as you can see in the top image here, a lot of those junctions, especially around the gingiva, we're going to actually see the keratinized epithelium sort of kind of slowly merge into a parakeratinized epithelium right before it becomes regular mucosa again. So you should be able to identify that. Our tongue also usually having keratinized epithelial surface. The other thing to make note is we do have our taste buds that you want to make sure you're aware of. So a couple of the structures that you can see in there, and we won't go into each and every one of them, but so in the posterior third of the tongue, you have the circumvallate papilla, and those look like these nice little, bowls or balls of taste buds. And then on the anterior tongue, you have the filiform, which was pictured here. These are like these little wispy ones. You have the fungiform and the foliate papillae. Those ones are going to be a little more truncated papilla. So just being mindful that those are there. They're going to kind of be disruptions of your normal epithelial surface. So with our gingiva, you can kind of see over in the far end there, just as we start getting to where the teeth are. So gingiva is going to be that region overlying the alveolar surface. And alveolar surface on any bone is really just, the mandible and maxilla, is where the teeth are attached to. And so that's going to be the keratinized stratified epithelium. You can kind of see it going from non-keratinized to keratinized, and then we get to the teeth, which is shown with the dentine there. So nothing too remarkable. It's really just going to be stratified squamous epithelium for the most part, with some variations here and there. So just be mindful of where those variations occur. So now moving on to the teeth. Teeth are a little more interesting because they have some mineralized components and they're not just straight up cellular. The teeth have to be really the most durable structure in our mouth because they kind of are their front person for mastication. So a lot of the chewing is going to take place on the teeth so we can get that grinding action going, make sure our food is properly deteriorated or broken down so it can be properly digested later on. So the outer surface is going to be really hard. It's going to be enamel created by ameloblasts. And this is mineralized component, acellular. So these ameloblasts will just going to secrete this and create this outer protective region on the tooth. Just beneath that is our dentine, which is going to be produced by odontoblasts. And odontine is a relatively hard structure as well, but not as hard as enamel. It's got cellular components, so it's got these little tubular structures from the odontoblasts, kind of creating the supportive network. For the structure there. And then just deep to that is the pulp chamber, which is really going to house all our lymphatic system, our vessels and nerves are going to be housed deep in. And so if you have an opening to that, maybe due to a cavity or some sort of tooth decay, which is breaking through the enamel and then the dentine, that's where you can start seeing some painful tooth pathology there, because it's actually getting a direct connection, communication even, to the nerve supply in that pulp chamber. The lateral aspects of the tooth, the tooth and kind of all around where the tooth touches the alveolar surface on either the maxilla or mandible, you're going to have this periodontal ligament, and this is dense connective tissue that's really just going to hold that tooth in place, make sure it doesn't fall out, and you can get infections and inflammation of that particular ligament, and that'll cause problems as well. But histologically, you can usually just see it as dense connective tissue surrounding these. As far as teeth numbering, just in case you're ever curious, so we start on the upper right, and we go 1 through 16, drop down to the left, and go 17 through 32. So adults should have 32 teeth, typically. So if you're ever in the dentist's office and they see the numbers broken down, you can kind of correlate to what tooth they're talking about. Children are a little bit different. They don't have the full 32 gambit of teeth, and depending on what age of development the child is at, they might have all their teeth in place at any given moment. So they actually use a lettering system going from A to T, depending on what we're looking at there. I won't expect you to know the children lettering, but just be comfortable with the adult lettering of teeth. And then in the maxilla and mandible, the bony structures of our oral cavity here. So the mandible you should be really comfortable with, going back to our anatomy. So again, making sure you know your two processes. So you got your coronoid process, which is going to be the attachment of your temporalis muscle. And then you got the condylar process, which is going to be sort of the area where the TMJ joint forms. And so you got the articulative discs in that mandibular fossa. And that helps us create that hinge joint so we can effectively chew and even get a little bit of a side chew going on. So most predators can't do that, but we can. It helps us grind the food effectively. Additionally, you've got your alveolar surface, which is going to be the region where our teeth are formed, and you'll see the same thing on the maxilla. So anywhere that teeth are in contact with the bone is the alveolar process or alveolar ridge. I'm not too picky about the mental foramens and the the mandibular foramens and the mental foramens. Those are more anatomical terms. Just be mindful that when you see those holes, what's coming out of there. So you have your inferior alveolar nerve going into the mandibular foramen and then exiting the mental foramen. You have your mandibular angle, which is going to be kind of the side joint, going up to the ramus, which is the flattened point there where your processes are, and then the little mandibular notch. So just some basic structures. So that if you're looking at these, you're most likely going to be able to identify in a mandible which structures you have and what you don't have. So maxillas are a little bit different. They're a little more convoluted, I would say. But some of the structures you might see if you got a whole maxilla, which is not often the case, is you can see the maxillary sinus within there, as well as the palatine process, which is part of that hard palate junction there. But realistically, if you got a specimen like this in the lab, it's going to be really hard to tell which components you have because they could be taking various structures from the maxilla. And that's why we probably won't talk too much about or focus too much on maxillary resections in this particular lecture. So then let's go up north to our nasal cavity. So this should look, again, familiar from anatomy. So some of the main structures you see with the nasal cavity is our turbinates. So we have a inferior, middle, and superior turbinate. And these are these like little concha structures here. So you'll also sometimes hear them referred to as conchas. And right underneath those, we have our meatises. So corresponding to the turbinate, an inferior meatus, a middle meatus, and a superior meatus. And these are just the spaces for some drainage sites. So next we can jump down to the sinuses, which are going to be a site of pressure release. And we'll see these as basically vacant spaces in the surrounding bone. And they're often corresponding to the name of the bone that they're found in, surprisingly. So starting with the maxillary sinus, that's going to be the one that's in that maxilla bone. So we saw that here. in that gap space. And then it's going to drain into your middle meatus. Next is the frontal sinus, which is also going to drain into the middle meatus, and that's in your frontal bone up here, so you can usually say that above the eye. And then you got your ethmoid sinus, which is going to drain into the superior meatus and a little bit into the middle. And then finally the weird one, which is sphenoid sinus, and that doesn't drain into any of the classic meatuses. It actually goes into the superior sphenoid ethmoidal recess, which is going to be a little bit posterior to your superior turbinate there. And you can also notice that the turbinates kind of decrease in size as you go up. So again, being comfortable with those, especially if you get some specimens named, whether it's the terminate or even the septum, which is going to be the dividing point, you can kind of see down here of the nasal septum, kind of dividing the nasal cavity into two halves. So those are kind of specimens we'll see if we get sinus contents. Now, as far as the mucosa, this is going to be your typical respiratory mucosa. So it should be pseudostratified columnar epithelium with some cilia attached. And you'll see that actually lining the nasal cavity as well as the sinuses. They'll have some of that as well. So their sinuses are going to be covered with mucosa, which can be important because that could also mean they might have a site for cancer development. But overall, the purpose of this mucosa is to help filter, kind of warm up our air as it comes through the nasal cavity. So you might notice on a really cold day, especially if you're living in the Midwest here this winter, you take a deep breath and it kind of like seems like it freezes your nose. It kind of gets those nose hairs a little frosted. Well, you don't want the air, that cold air going into your lungs. So typically you'll get the cold sensation up in your nasal cavity, gets warmed up enough so by the time it gets to your lungs, you're A-okay. That's kind of the purpose of it. We also want our olfactory system to be effective. So some of the purpose of this respiratory mucosa is actually help grab some of those smelling particles that you might get, whether you like them or not, and kind of get them to be picked up by that olfactory bulb receptors so that we can transmit those smells back to our brain and see if we like it or hate it, and we're mixed feelings on it altogether. So finally, we have salivary glands. We have three main salivary glands we talk about in the head region, or I should say head and neck region. So you got your parotid, which is the biggest one, kind of right in front of the ear, anterior to the ear there. You have your submandibular, which is identified in the submandibular region, and then sublingual, which is going to be just beneath the tongue. And so all these ducts are, or all these glands are going to have ducts, which are going to help bring our salivase and our salivary fluids into our oral cavity and help basically get digestion up and running. And so anatomically speaking, they're just going to be glandular structures, lobulated, relatively unremarkable. They're not capsulated, so that can be a problem if you do get cancers in these specimens. They become harder to be contained by their borders. Histologically speaking, so you might remember these kind of classic demonstrations from histolabs. So you got your parotid gland, which is pretty much all serous gland tissue, so you should be able to identify that if you saw just nothing but serous. And when we talk about that, serous is basically these pink acini. So when they form that nice little circular gland structure, those are acini. And if it's all purple, or sorry, pinkish, those are serous glands. If it's clear, like we see down below with our sublingual, those are mucinous glands. So our sublingual, since we're talking about that, both sublingual and submandibular are mixed glands, but the sublingual is mostly mucinous glands, as you can see below, where submandibular is mixed, but mostly serous glands. And the other structure you generally see in your submandibular region is those serous demolunes, which they kind of point out down here, right there. So those are basically just like serous components. They kind of create like a little hat over your mucinous gland, kind of like a little hipster acini who's wearing his little beanie hat thinking he's cool. So that's kind of the structures for salivary glands. You should be able to look at a salivary gland histology and kind of identify which potential gland it will be based off the distribution of serous or mucinous glands. So let's start looking at the pathology and surgical specimens for some of the oral cavity stuff. We'll begin by taking a look at the teeth, gingiva, and some of the soft tissue in the surrounding oral cavity. So first up is gingivitis, and this all begins with dental plaques. So dental plaques, you might remember from your dentist telling you need to brush and floss in order to remove these plaques, or if you go in for a teeth cleaning, that's something that they'll try to scrub off with their little sharp tools. So plaque is just a biofilm created by disseminated cells in the oral cavity. What happens is they kind of just latch on to your teeth. In between that and a buildup of protein and some bacterial deposits, they start kind of creating this little shell. And for the most part, it's just this mineralized shell, and you can usually get it clean with toothbrushing, as well as using the floss. But if it's left too long, then you start getting calculus deposits and it becomes really hardened. These dental plaques become problematic because they create like a nice little warm environment for bacteria to thrive, and we don't want bacteria kind of sticking around being stagnant in our teeth. And the reason for that is because if these plaques find themselves close to the gum line, we can get inflammation of the gums, which is gingivitis. And you'll see this as an erythemus change in the gum line. There might be some bleeding and maybe potentially some sort of contour change. So usually if they do like the little tap test to see how eroded some of your gum tissue is between the teeth, that can be a sign of prolonged gingivitis. So if these plaques happen to stick around even longer, become these calcified dental plaque deposits, and you happen to have a sweet tooth, well, now you create the perfect environment for the bacteria to thrive. And what's going to happen is this metabolic breakdown of the sugar is going to start eroding into our teeth enamel and give us what's known as dental caries, otherwise known as cavities. So cavities are just this eroded enamel deposit from these acidic buildups of bacteria fermenting. It's usually sugary substance, but any sort of fermentation in the bacterial colonies can ultimately lead to caries. So it's definitely something you want to be mindful of. And so that's why it's kind of important to get those plaques removed when they're easy, rather than waiting for the dentist to scrape them away and ultimately cause you a little bit of gum bleeding due to a lack of flossing. And not to say I'm guilty of that. So let's say that the inflammation starts getting a little bit deeper into our gum line. Now we start risking inflammation of the periodontal ligaments. And if you remember, those are the ligaments that are going to keep our teeth attached. And in this image, you can actually see that the erosion of the gum line is pretty severe, and we're starting to see the tooth roots. So one thing to look at too is the association with various diseases. So immunocompromised patients and patients with HIV tend to have a higher incidence with periodontitis than normal patients. You also see this with Crohn's and diabetes as well as Down syndrome. So those patients tend to be at higher risk for these. But any sort of long-standing inflammation of your gum line can ultimately lead to tooth loss as the alveolar ridge becomes weakened and unable to hold on to your teeth. Let's go ahead and take a look at some of the benign lesions of the oral cavity. So starting with the pyelogenic granuloma, these lesions are often found in young adults and children as well as pregnant women. Their appearance is quite alarming and they do tend to grow rapidly, but overall they're a pretty superficial lesion that often regresses on their own or can be cured with surgery. In the rare cases, you can get calcification deposits and these become a peripheral ossifying fibroma, which means you have to do a bit deeper surgical resection. But if they're caught early enough, if they tend to regress, usually it's not an issue. Their appearance, they kind of look like an erythroplakic lesion, so that can be worrisome. They have this red to purplish color, usually are ulcerated, and they have this higher amount of vascularization that kind of leads to their color. But most of the time, a non-issue. So next we'll take a look at peripheral ossifying fibromas. These can occur de novo, starting from a periodontal ligament attachment, or they can arise from chronic pyelogenic granulomas. These do appear very similar to those pyelogenic ones with the ulcerated red to purplish color, but on palpation you can feel that they're actually quite firm and kind of a pseudo-bony substance. They tend to be lodged really close to the bony region of the mandible or the maxilla, depending on where they're at. So if we're going to resect these surgically, you oftentimes have to get it right to the periosteum. Otherwise, you'll start getting some reoccurrence with these. They tend to be found in young individuals, teenage women, and teenage women tend to be the highest incidence. But again, relatively benign and unremarkable, so just a basic surgery. Finally, we have irritation fibromas, and these are trauma-induced, so some sort of mechanical irritation to the gingival dental dividing line will often lead to a sort of development of these fibrous masses. And you can actually see in the bottom image here, that's an irritation fibroma, where the one above is a pyelogenic granuloma. And keep in mind, pyogenic, and peripheral ossifying do look very similar, so this one could theoretically turn into a bony calcified mass that would require some excision. But irritation, unremarkable again, they can regress on their own or surgical resection can be needed. So just one of those things that if you can't wait to eat those pizza rolls and you're just popping them in your mouth when they're super hot, you could get yourself a irritation fibroma. So speaking of eating pizza rolls too soon, let's move into canker sores or aphthous ulcers. So I'm sure this is something that we're all relatively familiar with, and we might have all had one at some point in our life. And we can all attest to the fact that they're relatively annoying, despite being very common. They do tend to be painful if you happen to eat certain foods, particularly acidic foods. And they present with this ulcered sort of erythematous look to them, and they contain some granulation tissue, and you usually get some sort of exudate associated with them. Now, overall, there's no real known cause or association, but you do happen to see an association with irritable bowel disease, such as Crohn's disease. However, again, these will often regress on their own. I'm just realizing, like the comic, we all probably do that. But these tend to regress on their own. You just kind of have to deal with the pain and suffering for a few days while you go through that. So another type of vesicle you might see in the oral cavity are these ones induced by this herpes simplex virus. Now what's going to do is create these little fluid-filled vesicles that you can see in your oral cavity, and these contain a lot of viral inclusion cells. Now what happens is these vesicles burst, well, then you're going to get virus kind of everywhere, and it helps kind of continue the spread. So it's ill-advised to burst these. And usually we'll see these clear up after a few weeks. However, it's never really fully curative. Unless you see those ads on TV if you're living with herpes. But what happens is this virus kind of hangs out in your local ganglia, usually your trigeminal ganglia, and just kind of waits for reoccurrence later on in life. Now the strand you often see is the oral cavity strand, which is HSV1, but in rare occasions, and depending on what activities you have, you might see the genital herpes variant, which is HSV2. So continuing with the theme of infection is oral candidiasis, but this is actually a fungal infection of the oral cavity. Now it stems from Candida albicans, which is a normal flora in your oral cavity, but if for some reason the patient becomes immunocompromised, you start seeing a proliferation of this bacteria, and it sort of presents as this kind of grayish-white deposits on your particular oral region. So it can be the tongue, the back of the throat, and even some of the upper oral cavity. There are three main types that you can see. So the one that's most common is the pseudomembranous thrush or pseudomembranous candidiasis. And this one is the one that you can easily scrape off this white deposit. And that's usually a good sign of being the fact that it is candidiasis. The other one you might see is the erythematous version. And this is kind of the same thing, except the gray-white deposits are actually red in color, but they can still be scraped off. So again, if anything can be scraped off, that's a good sign that this thing is probably just an infection that can be handled. And then finally, there's the hyperplastic variant of candidiasis, and this one's tricky because it's going to have that gray-white deposition on the oral cavity, except it can't be scraped off easily. And the problem with that is because now we can start including leukoplakic lesions into our differential diagnosis. So with something like hairy leukoplakia, which is a leukoplakic lesion, you'll get these white deposits kind of along your tongue or oral cavity, and again, these can't be scraped off. And another incidence that you'll see is that they're both, between candidiasis and hairy leukoplakia, they're both associated with immunocompromised patients. So again, that can be problematic as well. Now, hairy leukoplakia has an association with the Epstein-Barr virus, and so usually you can take samples of that and look for the viral inclusions of the EBV. But otherwise, there's no real clinical way to tell these apart without testing on them. But what this really is just a hyperkeratosis. So the upper layer of your epithelium is kind of just really active and really growing, and it starts to leave these white deposits with kind of irregular borders. They're a little more defined than what we'll see in the leukoplakic or the erythroplakic lesions, but they're not super clear. You know, you can kind of get patches like in the tongue here where it just sort of fades off, but at least you can kind of see where the white stops and the tongue begins. In the same realm of hairy leukoplakia, we can also get a hairy tongue. So this is kind of a bonus pathology that you might see. I don't expect you guys to know this one. I just think it's kind of a cool little trivial fact that yes, indeed, you can get hair on your tongue. You tend to see this in older patients, particularly more males, and it's really due to a lack of mechanical stimulation of the tongue. So what does that mean? Well, if you're not really eating too much, you get a buildup of this keratin, and it results in this hairy deposition. So do your part to prevent hairy tongue by making sure you're eating often. And make sure you're eating good stuff too. Chips are pretty good because they'll probably help scrape that stuff off. So you got my blessing on that one. When we talk about oral lesions, and these are something that usually the dentist will look for when they're kind of looking around your oral cavity, you can have two types: a leukoplakic lesion, which we just talked about, and erythroplakic lesion. And those are going to be very similar, except for the erythroplakic lesions are red. And if you remember with the candidiasis, we had that erythroplakic version of it where it's sort of red in color, but it can scrape off, and erythroplakic lesions themselves normally don't. So a couple of things to keep in mind is both can't be scraped off. The red erythroplakic lesions tend to be ulcerated, where if we go back to the hairy leukoplakic, you can see that they're kind of like firm and have this nice little, I wouldn't call it smooth, but this intact surface per se. Now, realistically, the erythroplakic lesions tend to be more worrisome because they have a higher incidence of turning into a cancer. You can see this in some leukoplakic lesions, but realistically you have to biopsy them to see if they're really worth anything. But that tends to be the concern. So if you see some sort of erythematous mass that doesn't scrape off, now you have to start worrying about oral cancer. There is an association with tobacco use, and you see these in men more than women, almost a 2-to-1 incidence. And this happens to be later in life. So when you're in the late ages, 40 to 70, you might see some of these lesions. So as well as far as epidemiology goes, they're pretty similar in the way they form and how they form. It's just a matter of what their differences are in leading to cancer ultimately. So definitely be aware of that. And with the erythroplakic, I don't think it says it on the slide, but a lot of times these have really ill-defined borders, and part of that is just the colorization. And even with these, they can potentially be carcinoma in situ or have carcinoma in situ on the peripheral edges. So a lot of times you're going to want to biopsy the whole thing just to make sure there's no cancer present. So when talking about cancer, the one we're most likely going to be talking about is squamous cell carcinoma. And I kind of find this interesting because this is kind of, when we get to the mandible, this is like our region is a pathocyst. What that means is, so these specimens are pretty darn cool. And I say that with the knowledge that, yes, this is a patient. We got to be mindful of that and always be mindful of that when you're in the lab working. But you'll see some interesting removals of squamous cell carcinoma that might push your grossing skills like to the extreme. You know, you really have to start reconstructing the face and where your margins are. So they're relatively interesting, and they're really something that you can see how far you progressed, especially in your clinical year. But I remember talking to a resident who hated cases like this, and it didn't occur to me why, but that's because it's always pretty much squamous cell carcinoma, which histologically is pretty unremarkable. And you can kind of see down here, it's really going to be that disruption of the epithelial surface, and you get some keratin pearls in there as well. Very easy to diagnose. So histologically, there's nothing going on, but grossly, it's fascinating. So I always like to tie these specimens as like a win for the pathocyst there. But when dealing with squamous cell carcinomas of the head, 95% of them are going to be squamous cells, and the other 5% are going to be varying degrees of melanoma and some lymphomas and things like that. So not only is squamous cell carcinoma the most likely and highest incident of cancer in the oral cavity, it also has a high incidence of association with the human papillomavirus, HPV. And that's the kind of virus that is typically screened for cervical cancers. So theoretically, if a vaccination works for an HPV-16 strain for cervical cancer, it could help prevent some oral cancers as well as some anal cancers, which are also associated with HPV-16, 16 or 19. But so that's a common association, something worth knowing as well, because it becomes a preventable cancer if we know there's a virus associated with it, which is, in my mind, pretty cool. So what's interesting about these cancers, as well as most squamous cell carcinomas, and I already made the association with cervical cancers, and you'll see a very similar thing when we get to the female repro system, is it has a very clear process of cancer development that you can kind of track. So you start with dysplasia, and ultimately you're going to get into carcinoma in situ, which is CIS. And when carcinoma in situ, you have these dysplastic cells that are highly mitotic, but they haven't crossed the basement membrane yet. And until there's invasion, you can't call it carcinoma. And that's actually kind of an interesting debate among some pathologists even, because if it's carcinoma in situ, is it going to guarantee to become carcinoma? Or is it pretty much going to be a small percentage or a certain percentage, depending on the cancer type, that are actually going to evolve into cancer? And that can be something to discuss, because depending on that association of becoming cancer, well, now you can run the analysis of, should we do a resection or should we do a watch and wait? And so for some of these, if they biopsy them, they might do a watch and wait and say, okay, it's in situ, but it hasn't invaded, especially knowing the fact that resections in the oral cavity are going to be very life-changing for the patient. So they might not want to do that if it's only in situ at that time. but we don't want to wait and make sure it gets too invasive, because that becomes problematic as well, increasing the amount of resection needed. So typically when we do have these cancers, they're going to metastasize to your cervical lymph nodes as well as your radical neck dissections that you see here. So normally we have the lymph nodes along our sternocleidomastoid. So you'll get a radical neck dissection in association with a lot of these cases, and we'll talk about that towards the end of lecture as well. So these can also be tobacco related if they're not necessarily associated with HPV. And they can either arise from leukoplakic lesions, erythroplakic lesions, or just de novo, maybe due to a HPV infection or tobacco use. If it's tobacco use, typically that's going to be associated with that erythroplakic dysplasia change prior to becoming the carcinoma. So here you can see some cases of carcinoma, and we'll talk about just basic oral cavity soft tissue specimens in this part, and we'll go into what we see here is our mandibular resection. And we start including bone later on in the lecture, we can go into those types of resections. But if it's too close to the gum line, oftentimes they're going to do a mandibulectomy, just because the cancer is likely going to be invading in bone. And you can see the one here before the resection, sort of the midline there. Chances are that cancer is eroded into the bone, so they're probably going to have to take the anterior portion of the jaw for that patient. So here are some of the local sites that are common for the origin of these oral carcinomas. Now, ideally, you'll see, or you'll want the cancer to develop in site 1 and 2, the anterior portion of the mouth, because that's something if you go in for your routine dental cleaning, the dentist might be like, hey, there's a weird reddish lesion there, potentially cancerous, we might want to biopsy that. The problematic ones are when you start going to the back of the soft palate or the base of the tongue. Now, the base of the tongue can be extremely problematic because then it can also potentially involve the larynx. And I did get a specimen where it was a complete tongue because the tumor was at the base of the tongue, and a complete larynx, all in one specimen, because the tumor is just, there's no other way to resect that without involving at least the tongue completely, or part of the larynx, or at least the upper portion of the epiglottis. So those are probably the worst sites, but these are also problematic because you don't see these until it's too late. So these are often diagnosed much, much later, and they've already become quite advanced at that point. So here's some of your oral cancer stats that were taken from the SEER data site that you can look at. And you can see that overall these cancers aren't as prevalent in the US population. So they only account for about 3% of cases. Roughly about 50,000, 53,000 of cases are expected, at least this year. So that number fluctuates very little. And about 1/5 of those are going to die, so they only account for less than 2% of cancer deaths, 1.8%. And I believe the amount of deaths are about 10,000 to 11,000 years. So these can be quite treatable. Usually the survival rate is about 2/3%, so 66% of people who have these can usually be treated with whether it's a surgical resection or chemo or radiotherapy, and the outcome is very favorable. But some of the things to consider for risk factors, like we already talked about, is smoking and alcohol, HPV infections, whether you're male, so the males have the higher incidence, and we saw with those leukoplakic and erythroplakic lesions, that's like a 2-to-1 occurrence, and African American descent also tends to have a higher incidence for these cases. So just some things to keep in mind when looking at oral cancers. So let's take a look at some of the surgical specimens we'll see for this particular unit. So here's some of the ones we'll talk about, with the exception of the mandibulectomy. So that's a surgical specimen kind of associated with this, and I included it here just to keep your mind primed, like, oh yeah, there's a good chance that any sort of those gingival cancers are probably going to be a mandible or potentially a maxilla, but we'll take it up to a glossectomy for this particular thing and then continue on. Hopefully that makes sense. All right, so the first two are pretty straightforward, teeth and mucosal biopsies. So starting with biopsies, these should be relatively unremarkable for you guys. Really, you're just going to measure the small fragments. If there's multiple, you can give a range. In an aggregate measurement, you'll describe what they look like and submit them entirely. And usually these can be things for like erythroplakic or leukoplakic lesions, and the goal is, let's rule out cancer, because if you think about the hairy leukoplakic lesion versus hyperplastic candidiasis, versus even potentially some sort of carcinoma in situ that just happens to be maybe a little leukoplakic itself, well, the biopsy is really going to be the only way you can determine that, because clinically it's not going to present any differently. So oftentimes that's what they're looking for. So they can do a shave sometimes, or they can just do like a punch biopsy and go from there. Teeth, are pretty much always going to be gross only. I have seen pathologists want to decal them, but I mean, decaling them is going to take forever, and as well as it's going to leave you with not a whole lot to look at. So typically you'll get these, and what you want to do is just give a number of teeth. Ideally, you'll give the dimensions. You can give a range of measurements, and then you can give an aggregate. And you'll do the SSCCPT. You'll describe any caries or other sources of decay or potential inflammation. If you happen to see soft tissue attached, you can talk to the pathologist or the PA and see if you want to submit that as well, or if you want to make sure you submit that separately so it doesn't get destroyed by the decal. So anyway, say do not decal teeth. Like I said, somebody might want you to do it. You can do it to see what happens. Just for funsies, I had a couple that were done. We just put them in decal to see how long it would take, and I think it was like 2-3 days before it actually got to the point where you could cut it. So it just depends, case site specific, but typically they're going to be gross only. So again, unremarkable specimens. Additionally, we can get tonsils. Now these will be covered in the heme lecture, so we'll kind of just do an overview. So for this particular lecture, I'm not so much concerned with knowing this particular prosection, because you'll get tested on it much later, but it's something to be mindful of, because tonsils can be a primary site for squamous cell carcinoma in the oral cavity. So when you get these, you want to make sure you review the patient history. You might get tonsils that are relatively benign for your sleep apnea, and sometimes those are gross only, or they can just be an enlarged inflammatory lymph node. So really you're just going to rule out things like maybe potentially lymphoma. And if that's the case, well, now you want to keep it sterile, or potentially for carcinoma. And maybe you don't see a lesion, or maybe there wasn't a lesion in the history, but what you'll learn is if there's an unknown primary, so let's say you get metastatic lymph nodes along your sternocleidoid mastoid, if they don't see a lesion, there's a good chance that it might be tonsil in origin. So a review of the history is really important for these cases. You're going to describe the external surface, measure them in 3D, do the SSCCPT. If you're not sure if this is for cancer or it is for cancer, you're going to want to ink the margin, and then we can serially section perpendicular to the long axis. And then look for the cross sections, take representation to the margin, and additional representative sections as well. Now, one thing you might see on these are these little friable deposits on the surface, and these are actinomyocytes. They kind of look like sort of an exudate coming out of the surface of the tonsil, but they kind of got a greenish color to them. Those are relatively normal. They tend to be just a normal colony that's found in tonsils, but you can describe them if you wish. And then, depending on what the history dictates, you can submit them entirely, submit representative sections, and maybe you'll need some for flow or cytogenetics. So now we look at the tongue, or the glossectomies, if you will. So you can either get a partial glossectomy or a total glossectomy. Now it really just depends on where the tumor is. So I mentioned the base of tongue squamous cell carcinomas. Those are pretty much always going to guarantee you a total glossectomy. But if it's something on the lateral side of the tongue, they can probably get away with just a partial side of it. So if we go through the motions again, you get the specimen. We're going to review the patient history, make sure we rule out any cancer or where the likelihood of cancer is. We're going to measure the specimen in 3D. We're going to describe our size, shape, color, consistency, patterns and textures, all that fun stuff. And then we're going to ink it. Now, the margin can be either inked, if it's just one total glossectomy, just ink that posterior margin. And if you want, you can actually create a lateral or right lateral side and left lateral side to differentially ink them. But one color is usually sufficient as a posterior margin. If it's a partial glossectomy, well, now you have a medial margin to be mindful of, and sometimes even an inferior margin depending on what was taken. So you can ink those differentially as well, having up to 3 colors for these specimens. So really we're going to look for tumor invasion and the depth of invasion. So even though the tongue's kind of like a enclosed set of epithelium, depth of invasion is important in these cases. So once you serially section the tumor, you're going to measure the greatest dimension, and you're going to see how far it goes into the extrinsic tongue muscles, which are just mainly your bulk glosseous muscles to be mindful of. So when you serially section these, you're going to make sure you get the depth of invasion, basically looking at how far it extends in those extrinsic muscles on top of the original 3 dimensions that you accrued. So keep that in mind because that is an important factor for staging. Now the sections you're going to submit are tumor at its deepest point of invasion, tumor to margins if you can, or not. If there's no tumor close enough to margins, you can take shaves of each margin, making sure you represent them. And then you can take additional representative sections of the tongue. So tongues are pretty straightforward, easy to cut, and they're just kind of a big old chunk of muscle, so nothing too crazy. The one thing I will say about these specimens is they're kind of icebergish in regards to what the tumor is. So usually you'll see like an ulcerated little lesion on maybe the lateral surface of the tongue. And that'll only be a small portion of what the tumor actually looks like. And you can section into the tongue and realize there's this whole gigantic mass that didn't appear on the outside. So sometimes you'll measure the external surface with a erythroplakic lesion, and then you'll section it. You can do a new set of measurements as you see the whole tumor in its entirety. So something to be mindful of when you get these. So let's go ahead and take a look at the staging for oral carcinomas. Now this is going to be staging criteria for any sort of oral tumor that's soft tissue in origin. So what we're going to be looking for is things like size of the tumor, depth of invasion, as well as any sort of local involvement. Now when trying to review and study for your staging criteria, I kind of blocked out the most important critical steps down there, and those are the things I want you to focus on as far as staging. What is going to be the thing that makes it a stage 2 versus a 3, or 1 versus 2, etc. I'm usually not super picky on A to B stagings, the subsets, unless it's pertinent. In that case, I'll let you know. And so I'll let you know right now that I'm not too picky on these cases. So again, we're looking at 2 or 4 centimeters are cut off. Your depth of invasion, whether it's going to be minimal or up to 1.0 centimeters or greater, will alter the stage, and if it's involved in some of the local structures like bone. And typically bone involvement is almost always a stage 4 for a lot of these tumors. Something to be mindful of, and that's ultimately a section you'll take if present, or if you can at least get it, is tumor to bone to verify. So additionally, just like everywhere else in the body, melanoma can make an appearance in the oral cavity, so that should come as no surprise. And it's got its own staging criteria that's pretty much just a 3 and a 4. That kind of clues you into how aggressive these melanoma lesions tend to be. And realistically, it's just a matter of relationships to some of your surrounding structures. And other things to consider for this is your lymph nodes. So one thing that you'll need to be accounting for in the head and neck region, especially when we talk about radical neck dissections, is extranodal extension. And what that means is there tumor contained entirely within the lymph node, or does it make its way kind of through the lymph node capsule? Because that's going to change your end stage for your T, M, and N. So it's something to be mindful of. So make sure when you're doing your sectioning of your lymph nodes for these cases, you're being extra mindful of whether or not tumor is in the capsule or outside the capsule, and show those relationships when you submit those sections. So let's continue our journey and go up into the nasal cavity. Look at some of the nasal pathologies and specimens we'll receive there. So the first thing we'll talk about is infection of the nasal cavity. Now this is something that's probably not new to any of us, as we've probably all had some sort of allergic rhinitis or infectious rhinitis. And any sort of inflammatory response in the nasal cavity we'll refer to as rhinitis. It's just a matter of how it was caused. So in infectious rhinitis, which is essentially the common cold, what we'll see is some sort of virus, usually an adenovirus, an echovirus, or a rhinovirus, will start getting into the mucosa and causing an inflammatory response. And this leads to a thickened erythematous nasal mucosa that often enlarges the turbinates. And the problem there is with enlarged turbinates, we'll see later, is that kind of impinges on our ability to drain our sinuses. And so that's why we get some sort of congestion or potentially even headaches when we have a common cold. Now, if this infection persists, you can get chronic rhinitis, which can ultimately lead to scarring and may even involve the sinuses to get a sinus infection, something that we'll look at shortly. Now, let's contrast that to allergic rhinitis, which is usually something that's associated with an IgE-mediated immune response. And this is something that we'll see activated when we get exposed to some sort of allergen like pollen, fungi, animal dander, or even some dust mites that kind of get up. So when you're cleaning and you kind of get that air of dustiness, might start agitating your nose, and depending on the type of person and your IgE-mediated response, you might be more prone to getting a hay fever reaction than someone else who might just sneeze and brush it off. So sometimes in chronic infections, we can actually get the formation of polyps. So a long-standing irritation of that nasal mucosa will start to cause it to become hyperplastic and create these nasal polyps that can get up to 4 centimeters in length. So that's relatively impressive. Overall, these are pretty benign unless they start getting locally invasive, but they can also cause congestion in the nasal cavity and pretty much be very uncomfortable to deal with. They can also cause the blockage of sinus drainage as well, depending on if they're located in the meatus or near an adjacent turbinate. But usually when sectioning these and looking at them histologically, they're going to look like normal nasal mucosa with inflammatory cells likely present due to the inflammatory response. So here's kind of a breakdown of both polyps and infections. So you can see our nasal polyps kind of growing and making their way back to the posterior aspect of the nasal cavity. This one's coming right out of the middle turbinate, right in that middle meatus there. And so that could cause obstruction of the frontal and maxillary sinus drainage. Additionally, over here, when you have enlargement of the nasal turbinates, like you see in rhinitis, that's when you start getting that mucosa to basically be really enlarged and pinching off your potential nasal or sinus drainage. So if you look on the one on, I guess, your right, that's a normal drainage system setup. The maxillary sinus can drain into that middle meatus. However, the one on the left, this is what you might see in a rhinitis, so like an infectious rhinitis case where your terminates are actually starting to get more hypertrophic and inflamed. They enlarge and they pinch off any of that drainage system. So you can see now our maxillary drainage is not intact anymore, and so that's going to cause downstream effects as well if we're not careful or if it doesn't resolve itself over time. So if we do have long-standing infections in the nasal cavity, one thing we're worried about is this chronic inflammation can lead to a sinusitis. And we saw that the turbinates inflamed, it can cause that blockage, and what that blockage will do is leave fluid-filled sacs in the sinuses and create this nice, moist, fluid-filled environment that becomes a cesspool of bacteria, and potentially fungal infections as well. You can almost think of it like a getaway resort where all these fungus or bacteria are hiding out in the hot tub and just loving their life. Now, what this also leads to is empyema, where you get like a large deposit of pus because some of these cells are just dying off and creating this dead tissue, and that becomes problematic as well. So sinusitis can be an acute condition, but can give rise to chronic conditions as well if it's left untreated. And what that can do is potentially harbor really deadly fungal infections like mucormycosis, which I mentioned in the neuro lecture. And that's dangerous because if it gets into the brain, it can be really fatal. So something to be mindful of, and this can be treated if it's a chronic condition with things like sinus content removal. So they'll go in and they'll kind of just chip over the sinuses and make sure that they can drain effectively. In extreme cases, they can even do a deep nasal septal removal to make sure you're getting clear the blockage as much as you can. So what we can also get in the nasal cavity are papillomas, and these differ from polyps because these are actually neoplasms and not just hypertrophic epithelium of the nasal cavity. And these do have an association with HPV, so either 6 or 11, the benign variants. So like I said, these are neoplasms, but they're relatively benign and shouldn't be, usually don't become cancerous. Now the problem we will see in these is if you get certain types of papillomas, because of the location and just the limited environment in our nasal cavity, they can become locally invasive. And the ones we're most concerned about are these endophilic or inverted papillomas, they're often called. And that's what's kind of pictured here. And you can see rather than growing up and being a nice little polyp-filled structure, they actually grow into the surrounding tissue, potentially invading into bone and maybe even brain, depending on their location. So those become something that need to get removed because they can be maybe not malignant, but locally invasive and cause problems. And then you could still get carcinomas in the nasal cavity, just like the oral cavity. The only difference is these tend to be associated with an Epstein-Barr virus as well, like we saw with hairy leukoplakic lesions. You can get two variants of these, which can either be a keratinized version or a non-keratinized version. Now the non-keratinized version tends to have a better survival rate, around 70-80% for 5-year survival rate, where the keratinized versions of these tend to be pretty deadly, with only a 20% survival rate in 5 years. So they can be problematic. The other thing you can kind of notice here is excision of these becomes problematic. So we have to basically do maxillectomies for these to remove the cancer entirely, and those are often associated with moving things like other portions of the bones and skull, potentially even the orbital cavity and contents there. So excision can be rather aggressive for these types of tumors. So these tend to be associated with environmental insults or nitrosamines, depending on if they're not associated with the EBV. So it just kind of depends on the case, but something to be mindful of. So here is kind of a nice little historical context. This is a 19th century skull that looks like it suffered from some sort of nasopharyngeal lesion. And you can see the way it just sort of eroded the entire bone, nasal cavity, and pretty much all the maxilla. So highly aggressive, and they probably didn't have the effects to treat it like they would today, especially using things like 3D printed material that we can use for people's bone structures now. But you can see how difficult of resections these would be in general, even if it's just a smaller, less aggressive strand than this, maybe even just invading into half the maxilla, or the maxilla is on one half of the body. So a couple of noteworthy specimens that we'll talk about in this particular section is polyps and sinus contents. And again, maxillectomies will be a likely resection if it is a nasal carcinoma, but we'll save that to the bone section. We'll only talk briefly about those. It's not something I'll hold you accountable for, because nasal resections or even maxillary resections are just super extensive and really hard to pin down, because you kind of have to reconstruct what the surgeon did and what was actually removed. So we'll stick with polyps and sinus contents for now. So first up, nasal polyps. What we're looking for here is a brief description and making sure we rule out any potential for cancer. Because if this is a papilloma, potentially there is a slight increased risk for carcinoma versus a papilloma, versus a polyp, which is relatively benign. So again, you'll look at your patient history, make sure it's just either a polyp or maybe some sort of exophytic papilloma. You'll describe the external surface and note its size, shape, color, and consistency, pattern, and texture. These usually present with a gelatinous sort of, I guess what you would expect a polyp from the nose to look like. It's got this like gelatinous glistening feel that's kind of like tan pink. So usually these can be up to 4 centimeters in length, depending on the size of the tumor itself with the excision. Now what we're going to do is section these and look for kind of a gray-white to a gray-pink cut surface. It should also be kind of translucent, potentially could be cystic. That's relatively common with these specimens. The things we do want to pay attention to is whether or not there's bone fragments or calcification deposits, just due to prolonged inflammatory responses. And if we see some firm white cut surfaces there, that's usually an indication of maybe a papilloma or potentially a carcinoma. And so those things should be sampled extensively. If you can find the margin on these, go ahead and ink it just in case. Better to do that before you section it rather than afterwards finding a tumor. And then you can serially section it. And if there's cancer, you can measure the lesion or submit the specimen entirely depending on the size of the specimen. So sinus contents are a specimen that you're probably going to see commonly in the lab. These are going to probably make an appearance throughout the rest of your PA career. And really they're just an attempt to alleviate chronic sinusitis that isn't responding to any sort of other treatment or antibiotics. In that case, they're going to go in and just open up or remove any sort of obstruction, blocking the nasal drainage. That could be polyps, that could be inflamed tissue, and that could be potentially even bone. And so what these things, these specimens come as is there's going to be a collection of soft tissue, cartilage, and bony fragments. And you can either just get it sinus contents or you can get sinus contents and turbinates, and you're going to process these the same way. So what we see in the image here is pretty much what you'll expect as a specimen. So there's just going to be an aggregate of tissue. So what you can do is just kind of measure the aggregate in 3 dimensions, describe the type of specimens that you have, if it's bone, cartilage, or soft tissue, and then you're going to submit sections. And usually you're going to decal all of the specimens because they're going to have bony tissue attached. But if you can, try to get 1 cassette of soft tissue just to make sure that you're not damaging the tissue with decalcification. And usually places, hospitals tend to have a standardized cassette submission for sinus contents. Most places it'll be 1 cassette, sometimes 2, I think up to 3 if they're really aggressive. But just some representative sections of the tissue should be fine. You're not really expecting to see anything other than inflammatory tissue for these specimens. So when we do look at the staging for nasal carcinomas, the one thing that should stand out if you're reading through this chart here is that size isn't an issue like we saw with the oral cavity. So an oral cavity, depending on the size of the tumor, that's going to dictate what stage you might fall into. But with oral tumors, it's pretty much all about local invasion. So you just kind of have to know what's involved and where that tumor is located at in the nasal cavity, and that'll help guide you to the stage that you're looking for. So just make a note of the key structures that are involved in each stage, so that if you were asked, the tumor involves some portion of the bone or the orbit, it's like, oh, it's a T4, T3, things like that. So a similar thing you'll notice with the maxillary sinus tumors. And so that's something important to be mindful of, is there is mucosa lining the sinuses, which means that there can also be tumors in the sinuses. But again, follow the same practice you did with nasal cavities, and just knowing that while size isn't an issue, it's all about the local extension, and you got to see what structures are involved. And usually for these, because we're already kind of close to bone, it's high likelihood bone's going to be involved, or which bones are going to be involved. And usually the biggest thing is whether or not orbital cavity is involved or not. And then finally, melanoma makes an appearance like it always does. Same thing as the oral cavity. We don't have a T1 and T2, it's just T3 and T4. So just be mindful of that and knowing how aggressive it is. Nasal tumors do follow the same sort of lymph node designations that the oral tumors did, because they essentially metastasize along those same cervical lymph nodes. So again, we're looking for the extranodal extension and how prevalent that is as a key factor in identifying where your N of the TMN staging is going to fall. So as promised, now we get into the bony components of the oral cavity, the mandible and maxilla. So first we'll look at the benign pathologies, and then we'll jump into the malignant and talk about grossing. So we'll first talk about odontogenic tumors, and this is any tumor forming from tooth elements, and that can be amelioblast, odontoblasts, and any sort of the cells corresponding to those. Now, the more primitive aspect of the cells involved, the more likely these tumors are to be aggressive. However, usually, although relatively rare, they are usually benign tumors, and most likely causing some sort of local discomfort depending on the location. Now, these can be epithelial in origin, mesenchymal in origin, or a mix of both, and usually it's going to be a mix of different tissue types, depending on how those tissue types evolve. And the most common type of odontogenic tumor is the odontoma, and this is more of a tooth hamartoma rather than an actual neoplasm. And when we say hamartoma, it's basically a neoplasm that has the normal elements of the tissue type it's forming from. So it looks kind of like a tooth, but it's just growing a little bit abnormally and out of place. So these usually are early in adult life, so the second decade of adults. So the most common odontogenic tumor is the odontoma. Now, these are more likely classified as a tooth hamartoma than a tooth neoplasm. And a hamartoma is really just meaning that it has the elements of the origin species or the origin tissue, which is going to be a tooth. So it kind of looks like a tooth forming, but it's just a little disorganized and chaotic, whereas neoplasms tend to have one cell type that just kind of proliferates. So relatively benign in that case for these tissues. However, they can be locally aggressive, as you can see in the image here. That probably isn't too comfortable, depending on the site of involvement. So these typically occur in the second decade of life and are usually associated with an unerupted tooth. So like if your molars are kind of staying under the gum line, you might be at an increased risk for a odontoma. They're usually asymptomatic and only really are prominent depending on the location and usually the mechanical manifestations of those locations. But if you're looking at these on an x-ray, they show up as translucent spaces, meaning they kind of have a hollowed out cavity on the inside. So you can usually use that as an indication that there's some sort of pathology going on there. Here you can look at a couple of examples, and the one on the right is a good example of that, looking basically like a normal tooth, just kind of in the wrong place. And then you can kind of see So the next odontogenic tumor we'll look at is the ameloblastomas. Now these are tumors that arise from the amelioblast cells, which, if you remember, are the ones that produce the enamel on the tooth. These have an equal prevalence in male and females and usually occur in midlife around the third, fourth, and fifth decade. So the way they present is usually you're going to identify these on the radiograph because they're going to be radiodense, which means they're going to basically look like a nice chunk of enamel. They're usually going to result in some sort of asymmetric enlargement. So you can see in this gentleman, basically his jaw is just kind of more pronounced on his left side, or sorry, right side, backwards imaging. And so these can be cystic and slow growing, and usually they're not going to be too aggressive, but again, we have to worry about those local invasions and how they're developing. When trying to excise these, it's going to have to be a wide local excision, so sometimes you have to remove the entire jaw for these specimens. Here you can see an x-ray, and it's not really pointing to it, but the one on the far end there, that's kind of a characteristic of the amelioblastoma. You can see some of the cystic areas as well, so there's not a lot of enamel deposit in this particular section, but oftentimes it's going to be associated with those sort of tooth-like deposits in the hard calcified components. So here's a resection, again, wide local excision. You can see how the mandible lost its shape, and it's kind of got this irregularity to it. So it almost looks like some sort of bony tumor, but it's really just an enamely origined tumor itself. As far as malignancy is concerned for tumors, the one we're most concerned about is an osteosarcoma, and this is going to be presented similarly as you would see it in the rest of the body, although the jaw is kind of not a common site for these tumors. Usually you'll see them in the femur and some of the distal extremities. But these will appear as infiltrative aggressive lesions stemming from the bone. They'll present with that Codman's triangle, and again, if you remember from imaging lecture, that's going to be the one where the periosteum kind of pushes upward, and so creates like a sort of pseudo triangle. It's not necessarily diagnostic for osteosarcoma, but it's definitely associated with them. And they're going to have lytic and blastic regions. So on radiograph, these are going to have blastic regions and lytic regions, which means the blastic areas are going to be really radiodense, so you can't really see anything with them, and they'll look kind of white. And the lytic areas are going to be kind of cavitated spaces of radiolucidity. So these can be broken down into primary or secondary osteosarcomas. The primary variant is the one where the tumor occurs kind of on its own, and it follows the classic presentation of an osteosarcoma. Namely, you're going to have a young patient, usually in their teens, early 20s, usually a male, and it's going to be relatively prominent in the distal femur, tibia, or humerus, so some of those bones of the extremity there. So contrast that to a secondary osteosarcoma, and this is usually a result of some sort of malignant transformation of another process. So Paget's disease is a great disease because that affects the bones, and oftentimes that can stimulate an aggressive transformation into an osteosarcoma. So these typically occur later in life, usually above 50s to much later. And what you'll see is these tend to have a more problematic prognosis because of their development and association with an underlying disease process. So they might be found on or radiographs, or sometimes you'll notice that there'll be pulmonary metastasis in these, more often the secondary than you see in the primary. These do tend to find themselves in the same common sites. With the addition of them, they often find themselves in the pelvis as well. So here's kind of a breakdown of the sites, and you can see the facial region, particularly the maxilla and mandible, are not relatively prominent for osteosarcomas, but they can occur. And over here in our image, we got that nice little Codman's triangle scene bouncing up. I can't reach over there, but so you can kind of see that kind of pushing the periosteum through, but you can kind of see that mass with those little clear areas and the denser areas in there being lytic and blastic. So let's talk surgical specimens for these. So you can get a maxilla or a mandible depending on the location of the tumor, and you're going to process these relatively similarly. That being said, we'll focus on the mandible for this component, and the maxilla, kind of like what I did with the orbitectomies. Those are something that you'll experience hopefully in your second year, or maybe even later. Some pathologists have not even encountered these after years of working. It just depends on what your hospital does. But maxillectomies are problematic because they have multiple bone margins, soft tissue margins, and you really have to reconstruct what was actually removed. Whereas a mandible is pretty much just going to be a solid excision of one unit of bone, and there's only really two bony margins we're worried about. So dealing with the mandible, you only be tested on the mandible for this component. The first thing we're always going to do is look at our history, and then we're going to describe what we have. There should be some type of orienting features. For mandibles, usually you can just kind of orient it based off of the appearance of the bone, knowing that as you get posteriorly on the bone, it's going to start flattening out and getting that angle towards the ramus. So you can use that. If it's the smaller excision, sometimes there should be an indication of what's anterior versus posterior. Maxillas are going to be tricky because it depends on what they took out. So you're usually going to have some sort of surgeon help you orient it, or maybe they'll send down a document saying what was actually removed. But those ones are always kind of tricky, so I end up having to put the maxilla close to my face to sort of try to rebuild what the face might look like or what was actually removed. But mandibles, again, we'll stick with mandibles. So what you're going to do is measure each component that's attached. And so I like this image in Westra, mainly in the fact that it breaks down the components into individual parts. So if you're looking at the bone, we'll measure a bone by length and diameter. Now the bone is going to be surrounded by soft tissue, so we can measure that as like a cube component. And on top of the soft tissue is going to be a layer of epithelial tissue. So the soft tissue and epithelial tissue we can describe in 3 dimensions. And you don't necessarily have to measure the epithelial surface separately. Oftentimes you can measure that as part of the soft tissue component. So you can say mandiblectomy received measuring blank by blank by blank with a portion of mandible measuring blank by blank. But thinking about it in this kind of 3D shape I think is helpful to try to like keep yourself oriented in what sections you need to take. Ideally what we're trying to assess is all our margins. And so again, thinking back when we talked about the orbit resection, you're going to have to think of these as a cube. So that means there's 6 potential margins that you have to be mindful of 3 different tissue types. So that means on the bone, there's an anterior posterior margin. Super easy. Don't even have to worry about it. For the epithelial margin, it's a 2-dimensional surface, so you're just going to have the 4 margins to worry about, right? So you're going to have usually an anterior, posterior, medial, lateral. And then there's the deep margin, but that's containing all the soft tissue. So the deep is usually going to be your inferior margin, and in some cases, depending on the resection, you might get a portion where there's a little bit of superior margin attached as well, just because maybe they took it up on the cheek, and there's a little rim of excision indicated, so you're going to want to treat that as a superior margin. So you got to keep track of all those margins. And if you recall, just like with the tongue, where you sometimes see an iceberg effect, where there's just an itty-bitty lesion, and then when you section into it, it's pretty big. You got to be mindful for that too. So usually if you're describing each thing and then documenting the external surface, you might see a solitary lesion, and I'll measure that to all my epithelial margins. So I'll say there's a erythroplakic lesion measuring 1.2 by 0.8 centimeters, and it measures X number of centimeters to the medial, lateral, anterior, posterior epithelial margins. Okay. Then when we section it, we can get the greatest dimension of the tumor if that's changed in any way. And then we want to reassess our margins. So now you're going to have to document the inferior margins. So for purposes of demonstration, we won't really worry about the superior margin element. We'll just worry about 5 soft tissue margins, 2 bony margins, and then the 4 epithelial margins. Now your epithelial margins and your soft tissue margins can be combined. So if you can see here with that cube on the bottom, what they're done is they put the epithelial surface on top so that when you take your medial epithelial surface margin, it also includes your medial soft tissue margin, but you want to make sure you're indicating that it does include epithelial surface, or at least what you think is the epithelial surface closest to the tumor. So the most important thing here is making sure you're comfortable and aware of where your margins are, and you're going to ink those differentially. So typically, again, if we're assuming 5 different margins, we're going to ink these 5 different colors. So the 5 colors are medial, lateral, anterior, posterior, and inferior. We're not going to worry about superior yet, just the inferior. Okay, 5 colors. And so that's it. And then making sure you measure your tumor to those corresponding margins. Now the bone is interesting, and usually part of the margin assessment as well, but you can kind of measure it to the bone margin if applicable, or if it seems like it's separate from your soft tissue margin. Now, realistically, the most important part of the bone is making sure the tumor is not involved in it, or documenting it if it is involved into the bone. And then usually you can assess the margins corresponding that way. So after you've kind of described what you have, you serially sectioned to describe the cut surface, remeasured your tumor if needed, and recorded the distance to each of the margins, now what we're going to do is submit our sections. So you should have 2 bone margins, which is going to be anterior and posterior, and you can shave those off, and those will need to be treated with decal. And then you're going to make sure you get all the other remaining margins. So if we're going to include our epithelial surface with our soft tissue, that means we should have 4 of those types of margins, and then the deep margin as well. So you can submit additional 5 margins. So in section submission, theoretically you can get away with the 5 for the soft tissue and epithelium, and then the 2 for the bone, making 7 margins total. So hopefully that makes sense. And review the lab video, hopefully that'll help too. One thing I do want to note is you do not want to ink the bone margins. So getting ink on the periosteum is fine, but if you ink the bone margin, usually what you're going to do is get ink in the marrow, and it's going to bleed in. And what that can ultimately do is give a false margin to the pathologist, or make it look like the tissue is actually closer to the tumor than it really is. So don't apply ink to those margins, just cut them and take them separately, put them in the cassette without ink. Now, other sections to consider, probably the most important section for this specimen is tumor to bone. Tumor to bone will basically stage this to a T4. And if that's the case, that's it, your job's done. And I half joked when we'd work on these, if you see a tumor to bone section, literally you can submit that section with the margins, and that's kind of it. But if it's not in there, then you can take your other sections to document thickness, relationships to margins for the tumor, and additional representative sections of tissue. So in this case, this image here is just bone with a little bit of soft tissue and gingiva. You can get these with tongue attached. You can get these with like a complete mandible where you have essentially two posterior margins to worry about. So you have to document it, right posterior bone margin, left posterior bone margin. So those are just things to be mindful of with these. But again, think three-dimensionally and just kind of keep an alignment of where your margins are, and always remember your anatomic orientation. And I think that'll help you with these. Maxillas, you would follow the very same principle, but now you just have more to think about, because now you have, oh, here's a lateral bone margin, here's an inferior bone margin, here's a posterior bone margin and a superior. And usually they're a lot thinner, so you can clip them off and submit them. Some places will be okay with submitting bone marrow, but usually you just go and plan on doing a striker saw cut of the bone margins. So additionally, these specimens are often going to be received with a bunch of frozen sections. And so your site can dictate whether those sections are going to count as your margin submission or not, but the surgeon's going to submit the corresponding margins for to document the margin assessment for frozen, so they can make sure they got the tumor entirely. If you look here in this image, so the anterior soft tissue / gingival margin, notice that that's on the other side of the bone. So usually you're just going to shave that off and take a section because it's going to be difficult to get a tumor to the anterior margin. So just be mindful that the bone is going to potentially be in the way for some of your sections, and you shouldn't be upset about that. That's life. So here are a couple of specimens to kind of get you excited. So we've got a maxilla on the far right there. Again, you can see there's multiple different bony margins around. You can see the teeth are still attached to the alveolar surface or alveolar process. But trying to keep an orientation in this, and it's going to be almost identical rather than bone margins being part of it. Going to be identical to the mandible, except now our inferior margin is covered by mucosa, so we would have a superior soft tissue margin instead. Then you got a nice cross section over here on the left side of a mandible. And so here you can really see how easy this would be to orient, because you got the angle and ramus in the back there posteriorly, and then the anterior cut up here. Here's a couple other cases I think I had worked on in the past, but you can see how the inking schematic, I inked the multiple surfaces different colors. So it looks like medial would have been red, lateral blue, anterior yellow, posterior black, and then inferior is going to be probably green in this case. So this is probably when I was young and silly and didn't have my lockdown inking schematic, but make sure you're consistent with your inking. And this is actually a good point where you can really just settle on an inking side or an inking setup that you like, unless your site is very specific about it. And that way, if you always ink posterior margin black, if there's ever a mix-up when your sets are submitted and it's a black ink, you can say, well, that's always posterior. Keeping those kind of consistencies in your working really helps make your life a lot easier. And then it's just something you don't have to think about when you're grossing. So now we come back and revisit that orbitectomy specimen that I introduced to you in neuro, as well as a maxillectomy, which also includes a portion of eye. So you can see how advanced these surgical resections can get. And now if you look at this specimen on the left, not only do we include the eye, but now we have additional skin margins that we have to worry about, as well as mucosal margins. Multiple bony margins to worry about, relationships to the orbital cavity, a lot of things to consider. But at the end of the day, if you know what your margins are and you ink those margins accordingly, and you know that your ultimate task is to show tumor relationship to those margins, the specimen should be not an issue to handle. It might be daunting and it might take you a couple hours, but it's just about a margin assessment and making sure you get those relationships. So one of the things you probably are thinking about when you are watching this is, man, what happens after the patient gets those removed? That's pretty extensive, especially with that one with the maxilla and the eye. Well, here's an article that I found that usually they would do some sort of prosthetics, which could be some sort of non-reactive plastic, because you don't want anything to be eliciting an immune response to the patient. But now they started using 3D printing technology, which I find 3D printing is just fascinating, and I wish I had a 3D printer one day maybe. but they can actually just reconstruct the patient's face and create an exact replica of what was removed to place in there. And so you have this nice specifically molded prosthetic to replace what was essentially removed from the surgery. And I think that's kind of fascinating. So read that article when you are I guess bored or just want to dork out a little bit. It'll be fun. Good little read. So now moving on to our last primary region of the oral cavity is salivary glands. So we'll start with a benign pathology, xerostomia, and this is known as dry mouth in the common vernacular. And this is associated with Sjogren's syndrome. Sjogren's syndrome is an autoimmune disorder kind of associated with rheumatoid arthritis. What happens is our immune cells start attacking some of our salivary glands and mucus-producing cells. It makes it very difficult for them to supply moisture into the oral cavity and help get things lubricated and ready for digestion. Now, medications tend to work on this. You can use antihypertensive, antipsychotic, and antihistamine drugs to treat it. So it's really a treatable condition, but it's definitely not comfortable. In order to test for this, the only specimen we'll really get is a labial biopsy, which is essentially a biopsy of the lip just to verify that the mucosa-producing glands are intact or if they're being attacked by the immune cells of the body. So next up we have salidintitis, or inflammation of the salivary gland. Now this could be viral or bacterial, it could be a traumatic in origin, or it could be an autoimmune disease. But we see, just like any other sort of immune response, inflammatory cells within the tissue. And it can be either acute or chronic. And obviously chronic is when we start getting into scarring of the salivary glands, and that can inhibit any sort of salivary dispensing into the oral cavity. Usually, in order to kind of well off the infection, you'll see a mucocele develop in these specimens. And so what these can be, the mucoceles can be excised, or the specimen itself can be excised, and to just document the mucocele present. This can also lead to blockage, like I said, which in long-standing conditions can even create a silolith, which is a stone within the salivary gland itself. So now we move on to the sort of hybrid pathologies, which is a pleomorphic adenoma. And I don't know, these just are fun to say, they're fun to cut. There's just a lot of fun things about pleomorphic adenomas that I really like. And I don't know why, it's just kind of weird. They also say PA, so that's kind of cool, right? So these have a histologically diverse tissue involvement, hence the pleomorphism component. When we say pleomorphic, it usually means there's multiple tissue types involved, which could be epithelial, mesenchymal, etc. in that regard. So most of these tumors are actually going to be found in the parotid gland, and most of the time they're going to be benign. They're usually just painless masses that kind of you notice as a bulge in a firm area around the parotid gland, but you can see them occasionally in the submandibular gland or the sublingual gland. The problem with these is you have to get complete excision, otherwise they reoccur. They're commonly going to reoccur for that. Now, in rare cases, they can basically transform into a carcinoma. So when you're sectioning those, you want to kind of look for firm tan white areas, and those should be submitted and sectioned extensively. So if they do arise, but most of the time these are going to be cured once they're excised. If it's excised completely, you don't have to worry about sort of recurrence of those tissue cells growing again. Next up is Warthin's tumors, and these are kind of cool as well. Honestly, I guess a lot of the salivary gland tumors are pretty cool. So Warthin's tumors are these tumors that arise usually in the parotid gland. Again, you'll find most of our tumors tend to be parotid gland tumors. And that's probably just due to the size of the gland. It kind of leads to more problems and more likely sites of disorder. But these are going to be the second most common salivary gland tumor after pleomorphic adenomas. So most of the stuff you're going to get for Frozens on these are pleomorphic, or that for parotid gland are going to get pleomorphic adenoma, followed by Warthin's. Warthin's are interesting because they have a pale gray cut surface, and usually they're going to have a cystic appearance. When you cut into the cyst, you usually get this oily kind of gray-white to gray-tan fluid coming out, and you tend to usually be benign, but again, a small fraction can become malignant or locally invasive. These are common, and I mean super common in smokers. You almost have an 8 times higher likely occurrence rate in people who smoke for that reason. So now let's take a look at malignant pathology, starting with mucoepidermoid carcinoma. This is the most common malignant pathology seen in the parotid gland, and usually in the salivary glands completely. And it does tend to have a higher incidence of occurrence in the parotid gland. This is going to be a tumor that has a mixture of cell types. So you're going to see mucus cells and squamous cells. So this tumor is going to have ill-defined borders like we would expect with a malignant tumor, as well as mucinous cells and squamous cells kind of mixed together with little cystic cavities made up of mucin deposits. So again, the problem with these and the ill-defined borders and even the parotid gland itself, which doesn't have a capsule to keep intact, is it becomes easy for these tumors to invade local tissue, particularly the facial nerve, which, if you remember, is pretty much right behind that parotid gland, and so it doesn't take much for a tumor to involve that, which could potentially lead to facial paralysis, especially during operation. The second lesion we'll look at is the next malignant lesion. The second highest occurrence is an adenoid cystic lesion, and these are seen in about equal submandibular glands and parotid gland specimens. So these are smaller than the mucoepidermoid carcinomas. They're non-encapsulated. They're not as ill-defined as you would see with the mucoepidermoid, and part of that is just given their size. But they do have a tendency to invade the local nerve structures, and they have a tendency to reoccur even after excision. And that's partly due to the non-complete encapsulated borders that were exhibited with them. So just something to be mindful of, especially for that local aggression and the potential nerve damage that we'd see. Again, if we hit the facial nerve, we're risking facial paralysis, and nobody really wants that unless it's going to save your life because of a tumor involvement. So as far as specimens go, there really isn't a whole lot to worry about. It's either going to be a biopsy or the tissue itself for the submandibular gland. So biopsies, those should be old hat at this point. If you don't know how to do a biopsy, feel free to email me and I'll walk you through it. But we'll talk about the salivary gland prosection itself. Now this really applies to any salivary gland, whether it's a parotid, a submandibular, or a sublingual. We're really just going to treat this as a solitary soft tissue mass. Now ideally, again, we're going to look at our history, we're going to describe the external surface. Typically these aren't received oriented, so you can just kind of ink the external surface one color. If they do orient it though, you can kind of keep your orientation as best as possible, doing like a three-dimensional schematic with your 6 margins to really keep things in track. But like I said, a lot of times you're going to get parotid glands and they're not going to have any orientation, so you're just going to have to do your best to sort of ink everything and then just section it and look for tumors. A lot of times you're going to get a lot of frozen sections for these specimens just because of the area that they're in. There's going to be a lot of spots that are at risk for involvement, so they're going to want to make sure those are clear, especially when going in and removing these tumors. So as you section it, you're going to look around the specimen, actually just before you section it, see if there's any attached nerve structures or any other lymph node structures intact. If there is any kind of disrupted margins, they're not encapsulated. But if you don't see anything or it looks relatively normal, go ahead and just ink the whole surface. You're going to serially section it. We'll describe the lesion, describe if there's any nerve structures or any other structures of note on the internal surface, describe the size of the tumor, and then you're going to go ahead and look for lymph nodes in the surrounding structure as well, because of the general location, especially with like the submandibular gland, you can actually see lymph nodes probably come with those specimens as well. So just be on the lookout for those. Parotid glands, you don't usually see any just because of their location. We don't have a whole lot of lymph nodes in the face or even significant lymph nodes, but it doesn't hurt to do a quick little check. Now when submitting sections for these, what you want to do is make sure you get the tumor to the ink surface. So if we're not dealing with an oriented specimen, which I'm assuming at this point, basically just tumor to the closest margin. And make sure you documented that in your dictation. Tumor measures blank centimeters to the inked surface, and then you show that section. You're going to do the standard 1 section per greatest dimension, and then you're going to look for any other relationships. So if you do see some surrounding nerve tissue, you can go ahead and get tumor to nerve just to verify whether or not that's involved. You're going to try to get normal glandular structures, and those are going to be looking like a little lobulated tan yellow cut surface. So they should stand out compared to some of the other surrounding soft tissue. And then if you do find lymph nodes, you'll just submit those. So anytime you're dealing with a case, you always submit every single lymph node you find if you happen to find some. So even if you think something is a lymph node, submit it just in case. Could be, could not be, but it doesn't hurt to have that extra cassette. So looking at the staging and grading criteria for salivary glands, the grading is a little bit different. So normally when we grade tissue types, especially with the stuff we looked at earlier, where it's mostly squamous cell carcinoma, and you're really going to look at a low-grade tumor where it maintains sort of the original cell types, to a high-grade tumor where it's sort of pleomorphic and we can't really determine what the cells look like. That's your standard for grade determination. But in salivary glands, it's really going to be based off the cells that are present and whether those are differentiated or non-differentiated. So we don't often be doing a grading of these salivary glands, but it's something worth noting that it really comes down to the presence or absence of certain cell types. Instead, we'll look at the staging. So a couple of things to note for the staging of salivary glands. Again, I put the key structures or the key things to note in the bottom there, so you can kind of use those as points of reference. But again, we're back to looking at the size. The size matters in this. And again, it's 2 to 4 centimeters. So make sure you're documenting that and knowing where those cutoffs occur. And then you want to look for local invasion. That's usually a common thing as well, like we saw with the nasopharyngeal, but we also saw that with the oral. But the biggest thing is we don't really have depth of invasion because this is a parenchymatous organ, so there's no depth point of reference to really utilize. So just size of the lesion and anything locally invaded. Again, when we're looking at the lymph node involvement, we're going to make sure we document extranodal extension and how much or how prevalent that is, because that's going to be very important to how these stages pan out. And one thing to note, unlike the other areas that we looked at, we don't really worry too much about melanoma in the salivary gland, typically because that's an epithelial surface that we're worried about, so there's likely no melanoma there. But just the lymph nodes and the salivary gland staging are important. Last but certainly not least is the radical neck dissection. So these are also covered in the larynx, and that's pretty much it. But any sort of head and neck pathology, we're going to talk about radical neck dissections because that's kind of the path you're going to take when assessing lymph node involvement, is doing a neck dissection. And the number of levels you take is really going to be dependent on what your findings are. So it's important to know and be comfortable with how those look. So we have a breakdown of what regions we're talking about when we look at a radical neck dissection, and kind of the distribution of what cancers you're worried about and how prevalent the spread would be. So looking at the image on the left, you can see the distribution of lymph nodes in the neck and lower head region. So notice we got some on the submandibular region, and then they kind of go along this pattern of the sternocleidomastoid and then sort of lie in the base. And so we create this like little Z pattern on our neck. So going, oh, sorry, I can't seem to do it. But so it's kind of like a cool little Z. And those regions are numbered. Now, technically they go up to region 6, but we're really going to be worried about regions 1 through 5 predominantly. But if you want to get real nerdy, you can go and look at the 6th stage that they kind of added and talk about in the AJCC staging. And the image on the right is kind of neat because it really just shows you the likely sites of metastasis depending on what tumor you're looking at. And so that'll give you an idea what surgeons are going to send down what lymph nodes. And if it's a really aggressive tumor or something they're really worried about, they're obviously going to take down more of these levels. But these are the kind of first ones they might sample for potential frozen section in order to rule out whether or not metastasis likely occurred. So we have 4 types of radical neck dissections. So there's first is your standard radical neck dissection, which is going to include all the lymph nodes, your entire sternocleidomastoid muscle, internal jugular vein, and any accessory nerve and submandibular gland. So that's levels 1 through 5. So again, submandibular gland, SCM with IJV, and then you're going to get some of the posterior lymph nodes as well. Get that nice Z shape. So that's your standard radical. As you can imagine, that's going to be very debilitating to the patient if you completely lose one of your strap muscle or your neck muscles on the side there, as well as that internal jugular vein. So only in extreme cases do you really see one of these, and I think I've only ever seen one that included the entire SCM. It was really cool to see, and it made it a lot easier to actually gross. But what you're usually going to get is some sort of modified one. So I'll just go ahead and talk about the modified one. It's the one that includes just the lymph nodes in those designated regions, and we try to avoid the SCM, the accessory nerve, and the internal jugular vein. And as you can imagine, that's significantly less invasive. And so usually what we'll get in the lab when we get a head and neck cancer is you're going to get a modified neck dissection. Usually they'll call it a radical neck dissection, but just know that it's technically a modified radical neck dissection. You can also do extended, where you get everything, plus you're going to get some of the surrounding glandular structures and part of the trachea and the pharynx. I've not seen one of these, so if the radical neck dissection is quite rare, you can only imagine how rare the extended radical neck dissection is. And then there's going to be regional dissection, so this is even more common than your full-on modified, and that's where they're just going to say, all right, we're going to just take regions 1 and 2 and assess those for lymph nodes because it wasn't a really big tumor, and there's no reason to worry about extensive metastasis. If you do find some, we can go back and take more, but again, you want to assess quality of life for the patient. So the various sections, I won't go through each and every one of these, but you should be comfortable with the basic division. So level 1 is going to be the area of your submandibular gland, and often the submandibular gland will be part of the neck dissection. And it's something that if you've got as a specimen, the goal there is just section it and look for tumor like you would with a lymph node. So that's something I wasn't aware of initially, so it's kind of a nice thing to just be mentally prepared of. Everything else you're going to treat as an actual lymph node, but the submandibular gland, what they're looking for is there tumor in there? And if so, just make sure you submit sections to document it. Then basically 2 through 4 is going to be your sternocleidomastoid divided into thirds. And then you have the posterior triangle, which is 5. 6, the reason 6 is usually going to be documented as the anterior triangle, but again, not a lot of places are going to take that out. But usually just 1 through 4 is what we'll worry about and what we're classifying as your standard neck dissection there. So how do you go about prosecting these? Well, really, it's just a modified lymph node search. So if you can, what you're going to do is orient these specimens. Now, in an ideal world, they might send down each one as a regional compartment. So they'll say, here's a container of level 1, here's a container of level 2, here's a container of level 3. Just do them as 3 different parts. However, sometimes they'll just send them down and they won't even orient them. And it's just the modified, so all you have is lymph nodes, and you really can't. Just make sure you document in your dictation that this is not oriented. Other times they might put a suture saying like this is a superior aspect, and you know that you have levels 2 through 4. So then you kind of arbitrarily divide it into thirds. And then in some cases they'll actually put little numbers on which region you're in. So they'll have like a tiny little 1 stapled to the top part, 2, and then 3. So that's kind of nice too. So what you're going to do is orient it as best you can using the system that they designed. You're going to give a measurement of the specimen you have. If there is other components like your internal jugular vein, your SCM, and maybe even a parotid gland or your submandibular gland, you're going to measure those separately and just describe them as they are. And those are sections, so anytime we do dictate something, remember the goal is if you dictated it, you got to submit it. So if you do have a submandibular gland, like I said, submit that as if it was a lymph node. If you have sternocleidomastoid muscle, well, just take a section of that as a representative. And sometimes tumors can be involved in that as well, especially if you're dealing with extranodal extension, where a lymph node from level 3, let's say, is invading into the muscular tissue, and that's probably why they're going to have to take out the SCM entirely. So open up your internal jugular vein if it's there. Look for any thrombus that might be forming, potentially any tumor thrombi as well, which indicates maybe an involvement of the venous supply system. So that's worth documenting and submitting if you do see anything. And then as best you can, just describe the levels that you have, as well as the number of lymph nodes in each level. So it's really important that you keep them separated. So if you get the whole structure, then you have to make sure, okay, level 1 is treated in here, and I'm submitting those in X number of cassettes. Level 2 is here. I got 3 lymph nodes. I'll submit those in these cassettes. And that all has to be indicated in your dictation as well. So at the end of the day, it's all about documentation and making sure you keep yourself oriented. That's why I said sometimes the easiest is when they do the regional, and you know, here's level 2. I submit the 3 lymph nodes I found, and it's a known level 2 lymph node. So here is the ideal version where they indicated like, okay, here's level 2, 3, and 4 from the SCM. They put a little suture indicating the top, and then you just divide it into thirds. Notice it doesn't look anything like the little like Z formation we kind of talked about on the right there, mostly because they don't have part of the posterior triangle, nor do they have the submandibular gland. But this is what you're going to see. And it doesn't look like in this image that the SCM is attached. This is just a collection of connective tissue containing possible lymph nodes. So you would just cut off 2, section that, look for lymph nodes, submit those as 2, 3, 4, do the same thing. So again, I mentioned several times, extranodal extension is super important for a lot of the staging criteria for these head and neck tumors. And so what you're looking for in these cases is, so if you can kind of see way back on the left side there, that highly basophilic tissue is your lymph node. And what you see and what they're trying to point out is there's a little tumor that's kind of evaded past the capsule. So if you look at a cross section and there's tumor outside the capsule, well, now we know it's positive for extranodal extension. Definitely something to be mindful of. So if you do not notice it grossly, document it. But that's also why it's important to submit every single lymph node, because you want to make sure that you're documenting and accounting for any possible extension of that surrounding tissue. So here's a nice little cassette summary, and this is how you should be organizing your lymph node dissections for these. So they looks like they got one is from level 1. 2 is just the internal jugular vein section, but then you can see how 3 and 4 is going to be level 2, A5 is level 2 bisected, A6 they indicated is level 3 bisected. So that's the structure you want to make sure you're maintaining throughout the entirety of this. So keep them organized. I usually do one section at a time and then submit that before moving on to the next section, because it's really important that they can track that you don't have a level 2 lymph node in level 3, because that shows that the tumor is actually invading farther than they originally anticipated. So it can be important for the patient's prognosis and ultimate staging criteria. All right, and that's it for head and neck lecture. Not too shabby, but there's a lot of stuff to keep track of. Just remember to organize your specimens and keep mindful of your margins. Think three-dimensionally, but if you have questions, let me know, and I'll be happy to answer them. So thank you for joining me.